Today's Journal Club is based upon an article published in Human Reproduction Open with Dr. Zohar Saket as one of the authors, titled Cumulative Live Birth Rate After IVF, Trend Over Time and the Impact of Blastocyst Culture and Vitrification. Dr. Zohar Saket went to medical school at the Karolinska Institute in Stockholm and graduated in 2009. After medical internship, she went through a residency in obstetrics and gynecology, which was completed in 2016. Since then, she's been working at Sweden's largest reproductive centre and IVF clinic, Sahlgrenska University Hospital. She is consultant gynecologist, soon to be certified subspecialist in reproductive medicine and surgery. In addition to standard reproductive care, she's also experienced in specific areas with responsibilities such as being the head of the gamete donation program and the head of the fertility preservation program for transgender patients. Her field of scientific interest is prognostic assessments, IVF outcome, and upcoming techniques in ART. Published in Human Reproduction this year, this article was presented and selected for press release at the 2021 ESHRE Congress. She's also involved in an ongoing multi-center RCT regarding artificial intelligence and embryo selection. She's engaged in education at Gothenburg University in medical and ethical subjects, as well as involved in organizing a yearly conference for fellow fertility doctors in Sweden and Norway. She's interested in quality of care, being an internal auditor according to ISO standards at her current workplace. So now it's over to you, Zohar.
So, as David said, I work at the Sahlgrenska and the Department of Reproductive Medicine. These are my co-authors and the title of our article that will be presented today. Cooper Surgical retained me to give this lecture only, and I have no other relationship with Cooper Surgical, and I have also no other conflict of interest related to this lecture. Our study question was, has cumulative live birth rate improved over time? And if so, which factors could be associated with such an improvement? And the answer was that between 2007 and 2017, the cumulative live birth rate per oocyte aspiration increased significantly from 27 to 36.3%, in parallel with an increase in blastocyst transfer and cryopreservation by vitrification. So some background comparison between cleavage and blastocyst transfer, what is known? Well, first of all, there are some quite old and very small studies from the early 20th century, not applicable to today's clinical practice. And it's actually doubtful that it's possible to do ethically approved RCT with the possibility to include all patients, even the poor responders with very few retrieved oocytes. But we have some retrospective observational studies. First, the crew from 2019, it's from Belgium, and they compared unselected patients from 2 different time periods, with only cleavage stage transfers performed in one period and only blastocyst transfer in a later period. And they found similar cumulative live birth rate for day 3 and day 5 transfers. But when they adjusted for age and number of retrieved oocytes, a significantly higher cumulative live birth rate was found for day 5 transfer, given that the patient had a fresh transfer. And their results that improved cumulative live birth rate for those receiving a fresh blastocyst could suggest that a selective use of blastocyst transfer in cycles with a higher number of oocytes or embryos would be superior to performing blastocyst culture for all of our women. The DeVos article from 2016, also from Belgium, they had around 1,000 patients, They included only young women in their first cycle having more than 4 oocytes aspirated. They found no difference in cumulative live birth rate for day 3 versus day 5 transfer, but the earlier transfer policy, I mean the cleavage stage transfer policy, required a higher number of transfers to have a live birth, and thus a longer time to reach a live birth. And then we have the Cameron study from 2000, it was published in 2020, but the data set includes data only up to 2010. It's a large population-based study from UK with around 100,000 patients, and they compared cumulative live birth rate for cleavage stage embryos and blastocysts in the first cycle. And although they found a higher cumulative live birth rate in the blastocyst group, this difference disappeared in their adjusted analysis. And the transfer stage was only based on the fresh cycle, and no information was available on the embryo stage or for cryopreserved embryos or the cryopreservation method. Some background on vitrification. Previously, cryopreservation of embryos was considered a secondary treatment during IVF because there were rather poor embryo survival rates and also low live birth rates compared to fresh embryo transfer. But in the last few years, the situation has changed rapidly. The use of extended embryo culture to the blastocyst stage has increased, and also cryopreservation of blastocyst has, by vitrification, has considerably improved the cryosurvival rates. We have a study from Spain, the Fernandez Shaw from 2015. They included 120 patients, and they saw a significantly higher ongoing pregnancy rate for blastocysts, also on a cumulative basis, actually, when vitrification was used as the cryopreservation method. Some background on fresh embryo transfer versus the freeze-all strategy, which is a very hot new topic and debated a lot recently. It hasn't been shown that the freeze-all strategy is the best for all patients, but there are some studies proposing that freeze-all would be the preferred strategy in all IVF cycles. So let's look at these 5 RCTs. We have the Chen study from 2016. They found significantly higher live birth rates for anovulatory patients in the freeze-all cycles. But when you look in ovulatory patients in other studies, they show no difference in live birth rate between the freeze-all and the fresh transfer. There is a big study from the Nordic countries, Stormlund 2020, applying single embryo transfer. They saw no difference in ongoing pregnancy rates or live birth rate when they compared the freeze-all blastocyst group to the fresh blastocyst group in ovulatory patients. And then we have an article with unselected infertile women, the Bong from 2021, this year, from the Netherlands, and they saw that the strategy with freeze-all of blastocyst was actually inferior to fresh blastocyst transfer followed by subsequent frozen embryo transfers concerning ongoing pregnancy, cumulative pregnancy rate, and as I said, in unselected patients. So what was known previously can be summed up in the conclusions from this Cochrane review by Gluyovsky 2016. And they say that although there is a benefit favoring blastocyst transfer in fresh cycles, it remains unclear whether the day of transfer impacts also on a cumulative basis. However, in this review, all but one small study used slow freezing for blastocysts. Okay, so our study design, this is a retrospective, observational, population-based register study. And the inclusion criteria was simple. All oocyte aspirations performed in Sweden from 2007 to the end of 2017. The number of included complete IVF treatment cycles were 124,700. And the only exclusion criteria was oocyte donation cycles. We had our data from the Swedish National Registry of Assisted Reproduction, the QIVF. It was launched in 2007, and all IVF cycles are included, both public and private clinics. There is a full identification of the patient, making it possible to collect cumulative data from all fresh and subsequent frozen embryo transfers from individual patients. The data are public and posted as aggregated data. And all of our patients are in Sweden are informed about the registry, and although it's of course voluntary, it's extremely rare that patients choose to not have their data included. Hence, the registry has an almost complete coverage. The definition for cumulative live birth rate was taken from the Ziegers-Hochschild International Glossary on Fertility and Infertility Care, published in 2017. And it is the proportion of deliveries with at least one live birth per oocyte aspiration, including all fresh and/or frozen embryo transfers within 1 year, until one delivery with a live birth or until all embryos were used, whichever occurred first, and the delivery of a singleton, a twin, or other multiples were registered as one delivery. So in plain English, all embryo transfer, fresh or frozen, derived from one oocyte aspiration and performed within a year after the oocyte aspirations were included. And the time limit of 1 year was chosen since very few patients, less than 3% in the QIVF database, still have cryopreserved embryos after a year. Our primary outcome was cumulative live birth rate, and the secondary outcomes were live birth rate in fresh and frozen embryo transfer cycles. Statistics, we calculated crude odds ratios and adjusted odds ratios with 95% confidence interval obtained from using general estimation equation models. We had odds ratio and adjusted odds ratio for live birth rate in fresh cycles and cumulative live birth rate in fresh and subsequent frozen embryo transfer cycles. Calculations were performed both per OPU and per embryo transfer, and a p-value less than 0.05 was considered significant. We made adjustments for maternal age, blastocyst transfer, number of oocytes retrieved, and previous live births after IVF treatments. Missing information was very low. For maternal age, it was 0.4%. For number of oocytes retrieved, 0.04%. And those numbers were replaced by the overall means. For the variable number of previous IVF live births, missing data was 0%. And for the variable live birth, missing data was 0.2%, and we replaced that with no live birth. So, our results. The sample size. The study period was, as I said, 2007 to 2017. We had 61,313 women included, and they made 124,700 oocyte aspirations. More than 65,000 aspirations were made for women under 35 years, and almost 60% in women above 35 years. And this resulted in 38,403 deliveries with live-born children. And here are the results table over the treatment characteristics, as you can see here, and the years 2007, 2011, and 2017. So first, the number of oocyte aspirations showed a slow increase during the study period. A slightly higher proportion of women above the age of 35, but as you will see in coming slides, there was no change in mean maternal age. The ICSI rate is unchanged, around 48 to 50%. The set rate, which is very important, for fresh transfers increased from 70 to 84%. And for frozen embryo transfer, the increase was from 74 to 98%. The very remarkable change can also be seen for blastocyst transfers. For fresh transfers, we had blastocyst in 5% in 2007. At the end of the study period, it was 31%. But for frozen embryo transfers, we had 6% blastocyst in 2007. At the end of the study period, it was 88%. The number of oocytes retrieved didn't change throughout the study period. So here we have the number of oocyte pickups and live births by type and year of treatment. The first column is the oocyte pickups in number, and then we have deliveries after fresh embryo transfer, number and percent, deliveries after frozen embryo transfer, number and percent, and then deliveries regardless of fresh or thawed embryos, meaning the cumulative live birth rate, number and percent. In 2007, we can see that from all of the oocyte pickups, 27% led to a delivery with a live-born child. In 2017, the number was 36%. And if we look at this, at the contribution from fresh embryo transfer, we can see that in 2007, the contribution to the cumulative live birth rate from the fresh transfers were 22%, and it's the same throughout the years, ending at also 22%. But here you can see the additive value of frozen embryo transfers to the cumulative live birth rate. It was 5% in 2007, and at the end of the study period, it was 14%. And these results are shown even more visually in the graph that you can see here. So here are the cumulative live birth rates per oocyte pickup by year of treatment. The green line is the fresh or frozen embryo transfer, meaning the cumulative live birth rate. The yellow line are the fresh transfers, and the blue line are the frozen embryo transfers. The contribution from fresh transfer to the cumulative live birth rate stayed fairly constant during the time period. And while the contribution is, as I said before, the additive value of frozen embryo transfers increased steadily. The odds ratio for the increase per year was 1.039 and statistically significant. So this is a detailed table over the most important variables for success in ART. Because your first question might be, we might have patients with better prognosis throughout the years. So we have the mean maternal age, we have the maternal age, mean and standard deviation, number of oocytes retrieved, mean with the standard deviation, and the years. And as you can see, the mean maternal age was 33.5% and didn't change much throughout the years, and neither did the number of oocytes retrieved. This is the cumulative live birth rate per year of treatment, categorized in age groups above and under the age of 35. So the blue line are the younger patients, the gray line is the total, and the red line is the older patients above 35 years. The cumulative live birth rate increased for both age groups, following the same pattern, as you can see. The delivery rate was, of course, negatively affected by age. Adjusted odds ratio for 1 year age increase was 0.918. This is the cumulative live birth rate categorized by day of transfer. The yellow line is for blastocyst, the gray line is the total, and the green line is for cleavage stage transfer. And the cumulative live birth rate among oocyte aspirations here leading to an embryo transfer is, this cumulative live birth rate is when we have all of the patients that actually had an embryo transfer. So the cumulative live birth rate when at least one embryo transfer was performed increased, if you look at the gray line, from 30 to 43%. And the division between different culture days is the day of the culture when you had your last, when the patient had the last embryo transfer. It could be the one leading to a live birth, or being the one, the last one they had within a year after the oocyte aspirations. So if the last embryo transfer was a blastocyst, then the increase in cumulative live birth rate went from 36 to 53%. So this is the cumulative live birth rate per oocyte pickup by year of treatment, and now we have also applied adjustments. The green line is cumulative live birth rate, the yellow line is for fresh transfers, and the blue line is for frozen embryo transfer. The continuous line, you can see that there are three different lines. The continuous line is the actual value, the dotted line is with adjustment for age, and the dashed line is with adjustment for age and blastocyst. And what I want you to note is that when you include adjustment for blastocyst transfer, the increasing trend in cumulative live birth rate by year is substantially weakened for frozen embryo transfers. And here also the frozen embryo transfers are included in the total, indicating that the increase in live birth rate, particularly for frozen embryo transfers, is highly associated with blastocyst transfer. So, summary of our results during an 11-year period, 2007 to 2017, the cumulative live birth rate per oocyte aspiration increased significantly, almost 10%, from 27 to 36.3%. The odds ratio per year was 1.039, and it was significant if at least one embryo transfer per oocyte pickup was performed. Then the cumulative live birth rate increased from 30 to 43%. The increase in blastocyst transfer was remarkable for fresh embryo transfer from 5 to 31%, and for frozen embryo transfers from 6 to 88%. The limitations for our study, of course, it's a retrospective study where you can't rule out other confounders. Some frozen embryo transfer cycles might have been performed later than our time limit of 1 year and thus not included in this study. And also we don't have any data on dropouts, meaning patients that actually do have cryopreserved embryos but choose to not have them transferred. And we don't know if this dropout rate has changed over time. The strength, though, of our strengths of our study are the size and the completeness of our data, with all IVF cycles performed in Sweden included during an 11-year period. So how can these results be explained? Well, we know that a certain number of poor quality embryos on cleavage stage will develop into good quality blastocysts, 20–35%, with good implantation rates. And considering that these embryos previously were discarded at early cleavage stage, they can now contribute to the total number of available blastocysts and may increase the chance of live birth within that one oocyte aspiration cycle. And in addition, the use of vitrification as a cryopreservation method has shown improved cryosurvival rates, adding even further to the number of blastocysts available for transfer from the same cohort. And other possible confounding variables have not been shown in at least any controlled trial to have an impact. What are the consequences for the mother and child? Well, a shift to more blastocyst culture results also in a higher proportion of children being born after frozen embryo transfer cycles, which gives better perinatal outcome in terms of lower rates of preterm birth, lower birth weight, and small gestational age. But frozen embryo transfer in comparison to fresh embryo transfer have higher rates of high birth weight and large gestational age. And while the late consequences of being born at preterm birth or being small gestational age are quite well known, with increased risk of cardiovascular and metabolic diseases, the risk in the longer term of being large gestational age or born with high birth weight are less well documented. For maternal outcomes, the most prominent risk in pregnancies after frozen embryo transfer compared to fresh embryo transfer seems to be higher risk of hypertensive disorders of pregnancy, as demonstrated in both several large studies and meta-analyses. We have large Nordic population-based studies on children born after blastocyst transfer compared to children born after cleavage stage transfer, and they have found similar risk for most perinatal outcomes between the two techniques, while some placenta-related complications seem increased for blastocysts. Also, the change of cryopreservation method to vitrification of blastocysts seems reassuring, indicating that the freezing technique per se has no major influence on the perinatal and maternal outcomes. So, in conclusion, we have seen a substantial increase in cumulative live birth rates over time. And this is despite the increased single embryo transfer rate, resulting in low multiple birth weights, which is very important to note. And this is also independent of the most important variables for success in IVF treatment, such as maternal age, number of oocytes retrieved, and earlier IVF live births. And the most striking changes throughout this 11-year period is the transfer of cleavage stage embryos, which has shifted to blastocysts for fresh transfer, and the slow freezing of cleavage stage embryos that has shifted to vitrification of blastocysts. And this increase in cumulative live birth rate almost disappeared for frozen embryo transfers when we adjusted for blastocyst transfer, suggesting that blastocyst transfer actually has a major impact on the increase in cumulative live birth rate observed. Our results suggest that blastocyst transfer, particularly when you use it in frozen embryo transfer cycles and combine it with vitrification, is an important contributor to the improved live birth rates over time. And this gives a possibility for a lower number of oocyte aspirations needed to achieve a live birth, and also a shortened time to a live birth. Some references, and thank you for your attention.
Thank you for this excellent and insightful presentation. Let's now open up the Q&A session. So maybe I can start with the definition, really, of the study. Does the study definition of cumulative live birth rate as a proportion of deliveries with at least one live birth per oocyte aspiration within 1 year mean that it's possible that the data may be skewed in favour of more recent and possibly more effective embryo selection techniques such as morphokinetics and PGTA?
Well, first of all, we don't use PGTA at all in Sweden. But of course, many things have improved throughout these years. We have an overall better culture conditions generally, but there isn't a specific thing that has been proven to have such a major impact on the improvements seen.
Yes, good point. And you also in the study, if you count multiple pregnancies as a single delivery, is it possible that that obscures the implantation rate? And in that case, is the implantation rate an important parameter of the effectiveness of IVF treatment?
Well, what is important for the clinical practice is that you have a healthy mother and a healthy child. So if you would calculate multiple pregnancies as multiple deliveries, then that wouldn't be fair to what is important for the clinical practice, if you understand what I mean.
Absolutely, yes.
Maybe the implantation rate is important for some laboratory, for some specific studies, but in clinical practice, the important is that you have a healthy delivery and a healthy mother. You shouldn't count multiple pregnancy as multiple deliveries.
Okay. Please remember to submit any questions that you may have. We're really interested to know what you make of this very interesting study. Now, one of the things that is very noticeable in the Nordic data, and that is that, is there a reason for the consistently lower mean maternal age of patients undergoing IVF in Sweden, let's say, compared with other countries such as the UK, the USA, and Australia?
Well, a difference could be, it's a very good question. I don't know the exact mean maternal age in those countries mentioned right now, but I can think of a difference is that in Sweden and in northern countries, we have state-funded IVF treatment. So, yeah, patients are entitled to have publicly funded IVF treatments, and maybe you tend to go for that earlier than you would do if you had to pay for the treatment yourself.
Yeah, that's a really good point. I guess on average, I'd say that the mean age in the countries I mentioned, at least, is probably about 1.5 to 2 years older. I mean, there is subsidization of treatment in Australia in particular, but even so, the mean maternal age is definitely higher.
Closer to 35 in those countries.
Over 35, that's right. Yeah.
Okay.
Yeah. And another really interesting aspect to your data, and I think this applies to many countries. So it's just very interesting. Is there also a reason for the consistently moderate use of ICSI, for example, never really getting above 50% over that time period? Over time in Sweden, let's say, compared with many other countries, and do you think, for example, had there been more ICSI, would your results have been even better over time?
Well, interesting question again. I don't know the exact ICSI rate in other countries as the previous question, but what I have understood from studies is that even though you do more ICSI, you don't have more live birth rates. So the indication for doing ICSI should be a failed fertilization in one IVF cycle or a clear male factor. Other than that, there are no indication that ICSI would improve your live birth rate.
Thank you.
But you maybe tell me about Australia and other countries.
Well, certainly in Australia. Yeah, in Australia, and I'd say the UK as well, there's just been a progressive increase in the usage of ICSI, and like you rightly point out, for no obviously good reason. So it's just very interesting to see that in Sweden, at least, you've maintained a consistent rate of the usage of ICSI, which I think is commendable.
And I think it's important to point out that it costs more, and I don't know if maybe that's a factor for other countries providing more private treatments.
Yeah, I mean, it does cost more, yeah, in other countries as well. So again, you'd think that would be a disincentive, but nevertheless, rates of ICSI have increased over time, but not in Sweden, which is very interesting. So the other thing is that there's the contribution of fresh embryo transfers to the cumulative live birth rate, and you showed that was clearly very steady over time. But was that because, to counteract that, there's been an increased percentage of elective single embryo blastocyst transfers with time? So has that balanced it out, if you like, kept it at a constant rate with the fresh embryo transfers?
Sorry, can you repeat the question?
Yes, sorry. So was the contribution of fresh embryo transfers to the cumulative live birth rate steady over time because there was also, over time, an increased percentage of elective single blastocyst transfers?
So you mean that the fresh embryo transfers should have increased, but it didn't because we did more single embryo transfers?
Possibly.
Okay. I'm just trying to understand the question. Well, it could be, but We still do around 60% day 2 transfers. And yeah, we had a quite high single embryo transfer rate from 74 to from 70 to 80 something percent. It could be, I don't know the exact answer to that question, but
fair enough, that's fine. Did you you obviously adjusted for blastocyst transfer, and I know the purpose of the study was to look at how cumulative live birth rate has changed, moving from cleavage stage, moving from slow freezing to vitrification. But nevertheless, did you adjust for vitrification? And if so, was the increased cumulative live birth rate over time substantially reduced yet again?
Well, since we only did slow freezing of cleavage stage embryos and vitrification of blastocysts, we couldn't adjust for vitrification as a freezing technique.
Well, that's interesting because, again, in other countries, I would say that there was a gradual movement from, let's say, extended culture sort of took hold before vitrification. Yeah. So there was a gradual move from slow freezing blastocysts to vitrifying blastocysts. So again, it could have been partly due to that change in technique.
You know, Steve, I think we started with blastocyst culture quite late compared to other countries. Okay. We kind of waited until vitrification was possible, more than they did in other countries.
Fair enough. Okay. So there's another question that's come up from one of the participants in this journal club. They ask, have you looked whether these pregnancies were more from day 5 or day 6 blastocysts?
No, we haven't compared day 5 to day 6 because they go into the same category.
Okay, all right. And what about, there's been some studies suggesting there may be an impact of the duration of cryostorage. Again, did you see any influence of the time from cryopreservation to transfer, and did that affect the results in any way?
No, we haven't, and all of the transfers were made within a year after the oocyte pickup. So it's a difference in a couple of months.
Yeah, so there's no real extended storage, was there?
No.
Fair enough. And the other thing that often comes up in the literature is a possible increased monozygotic twinning rate in following vitrified blastocyst embryo transfer. Did you observe that?
Actually, thank you for that question. It's a very interesting thing that we are looking on in coming articles, but we don't have it in this study.
Okay.
So.
Well,
interesting indeed.
Maybe you'll have to do another journal club on that.
Yes.
And I guess it would probably be difficult to have mined that data to find out whether there was any difference in vitrification techniques, for example, collapsed versus non-collapsed blastocyst vitrification.
We don't have that specified data in the QIVF registry.
No, I didn't think you would. No. Okay. And what about the practice of doing an immediate transfer following warming or thawing versus culturing overnight? I mean, was there any data on that? Because of course, particularly for cleavage stage embryos, if you allow them to cleave overnight, to demonstrate their viability, not just their survival, then there's probably more likelihood of, again, choosing the best frozen embryo to transfer. Was there anything like that in the data?
So what is your specific question?
So the question was there any difference available in the data between immediate transfer of an embryo, or for that matter, a blastocyst, and transfer after 1 or more days of embryo culture to see whether the thawed or the warmed embryo was viable?
No.
So nothing like that. Okay.
No.
And I'm assuming that the best blastocysts were warmed first, or is there a different strategy in Sweden?
That's what we usually do. Well, you have to have a top grade blastocyst to freeze it in the first place. But if there are some smaller differences between the blastocysts, you always choose the best one first. Yes.
Yeah. So I guess one of the key questions is that given that the percentage of vitrified blastocyst transfers has increased much more in frozen embryo transfer cycles, which parameter is it? And I think your data probably shows it, but which parameter is it, blastocyst transfer or vitrification, that has had the most impact upon the cumulative live birth rate over time?
Well, it's impossible to answer that question because all of our frozen blastocyst transfers are cryopreserved by vitrification.
Yeah, of course.
So it's impossible to say which of them.
Yeah. So we've had another question, which is a very important one that's come in from one of the participants. Should all blastocyst culture be performed under reduced oxygen atmosphere of 5% oxygen? And I guess this is really important in terms of mitigating any risk of oxidative stress.
Yes. Well, this isn't anything that we have looked upon in this specific study. I know that it is discussed now in different studies, but it's not something that I can answer from my data.
Okay.
I don't know. Maybe you, as an embryologist, have more input on that.
Yeah, I mean, from my perspective, I would have said that the data that we have to date is unequivocal, that there's clearly a benefit to culturing embryos under a reduced oxygen concentration. And of course, if you do that, then you pretty much can prevent the kind of oxidative stress that you would see, let's say, under atmospheric oxygen. It makes sense. You need a certain concentration of oxygen present to mediate oxidative stress. So if you can reduce the oxygen concentration, then of course you can pretty much mitigate that risk. Okay, so sadly we've reached the end of the session. So thank you again very much, Dr. Sackett.
There are those we look up to, those who taught us everything, those we share our lives with, and those we look forward to meeting for the very first time. Though we all belong to a generation, not everyone has a chance to help create a new one. No more than one generation ago, the world of fertility care changed forever. With Louise, we saw what was possible with IVF. And today, she and millions of women, babies, and families have become generational symbols of courage, knowledge, progress, and change. But as the need for fertility care continues to change, there are challenges we must overcome. As global demographics are changing, fertility rates are under pressure. As technology is advancing faster than ever, clinics and patients still need the tools, time, and training to turn data into informed decisions. and the limited access to quality fertility treatment is a global reproductive issue that needs to change. At Cooper Surgical, we are proud to offer leading IVF and genetic testing solutions to clinics around the world. We believe in pushing the boundaries of what is possible, that together we can change the standards of fertility care to increase the time for patient support and consistently optimize outcomes. Change the journey in fertility care to reach a higher level of insight, efficiency, and trust. Change the access to fertility care to break down the barriers standing in the way of parenthood. That's how, together with her, him, her, they, them, we can make the change every generation deserves. A chance to bring new generations to life. Cooper Surgical, changing fertility care for generations to come.